has started.
Yep. Here we go.
Good morning, everyone. Welcome to today's medical grand rounds. I'm Dr. Mokshigandan from the Division of Endocrinology. Dr. Kruger is unable to speak to you, but she's still on the call and will be listening. She just wanted me to remind everybody that the vaccination process is underway, and we would encourage everyone to get vaccinated and encourage everyone that you see and who are eligible to get the vaccine to get vaccinated. With that announcement, I would like to introduce today's speaker, Dr. Michelle Griffith from Vanderbilt University School of Medicine. Dr. Griffith is currently an associate professor in the Division of Endocrinology and Metabolism at the Vanderbilt University School of Medicine. She graduated with honors from Carnegie Mellon, did her medical school residency and endocrinology fellowships at Vanderbilt University. She then went to University of Pittsburgh as an assistant professor. Although I must say that we interviewed her here and she, decided to go to Pittsburgh instead. She was the medical director of at the Center for Diabetes and Endocrinology at the University of Pittsburgh Medical Center, and she was also the clinical lead for the Endocrine Telehealth unit at University of Pittsburgh. As many of you might know, Pittsburgh has been one of the pioneers in telehealth, and she has been a part of it. She was there from 2001 to 2017. When she came back to Vanderbilt University as the program leader for the diabetes telemedicine program at Vanderbilt. And she's also the diabetes subject matter expert for the Office of Population Health at Vanderbilt University and the medical director of the Ambulatory Telehealth services for all of Vanderbilt University Medical School. So telehealth has been one of her passions, and she has been on the Endocrine Society Task Force on innovative models of care in diabetes. She has taken a lead role in promoting and improving the delivery of telehealth for diabetes and endocrine disorders, and to improve care in a variety of ways. In addition to that, she is an excellent teacher and provides excellent patient care. She has been a mentor for several students and residents. She has won awards both at University of Pittsburgh and Vanderbilt for her work on these. And today she will be talking about telehealth for diabetes, working for a better new normal. Dr. Griffith?
Thank you so much, Dr. Mokshigandan. It is a pleasure to be with you all today. Have no conflicts of interest. And my goals for today are to first briefly review types of telehealth, establish a common vocabulary. Then I'll cover some data on the efficacy for diabetes care via telehealth with a focus on video visits. We'll talk about what we've been doing at Vanderbilt, both at the system level and in our endocrinology clinic. Talk about the regulatory landscape as it stands today and where we might all go from here. I'd like to open with a patient case. This is actually a Kentucky patient, Mrs. G. She established with me here in Nashville in 2017. At that time, she was age 75. She's a retired nurse and an excellent historian. And she had been diagnosed with type 1 diabetes at the age of 70. Late, but it certainly does happen. She had been doing very well on multiple daily injections of insulin, but she suffered from hypoglycemia as well as hypoglycemia unawareness. Her medical history is also relevant for post-polio syndrome. She had onset of that in 1985, though she continued working as a nurse until 1996. At that time, she had a critical illness that led to some neurologic setbacks, and she's been wheelchair-bound since then. She also has neurogenic bladder and frequent UTIs. She lives in Western Kentucky near Hopkinsville, and she has a great relationship with her local primary care doctor. In 2018, we started her on an insulin pump and on a continuous glucose monitor. She was able to set herself up with that device's cloud service, so she could send us her data as needed. And this led to great improvements in her hypoglycemia. But a nuance of insulin pump therapy on Medicare is that Medicare still requires every 90-day visits for pump patients, regardless of their level of control. And she would frequently comment, as we were just chatting during our visits, that it was worth the trip, but I sure wish you had a clinic closer to me. And even at that time, I did have a telemedicine clinic in Clarksville, Tennessee, which is only about 30 minutes from her. But I could not see her at that location due to her Medicare coverage. And we'll come back to this at the end of the talk. So telehealth has a number of overlapping terms, and most of these do not have a single definition. So e-health is the broadest term. That actually does have a World Health Organization definition. So that's all use of information and communication technologies for health. Our next broadest is telehealth, and that can contain both clinical and non-clinical services. So things like health maintenance or health promotion delivered remotely can also be called telehealth. It also has both synchronous or real-time modalities like video visits, often called telemedicine, and asynchronous methods like e-consults and remote patient monitoring. Then mHealth or mobile health spans many of these categories. That's the use of mobile technologies to deliver health interventions or promotion. And finally, telecare is really the least well-defined term. This sometimes refers to telephone care, sometimes refers to telenursing. Point being that you do want to understand, if you're reading a paper about telehealth, really what the intervention was, because these terms are not very specific. I'm going to try to use the term telehealth throughout when I'm speaking about video visits. That's our local vernacular now. I sometimes do slip and still call it telemedicine. Another way to look at this, though, is that telehealth is simply healthcare. Everything we do in routine care is a part of telehealth. We're just delivering it in a different way. And I suspect we've all seen over this past year that the clinical setup behind a intervention is just as important as the technology we're using to deliver it. Telehealth is also an industry, and a significantly growing one. So some industry estimates projected that we would be having 46% of consumers using telehealth by the end of last calendar year, up from 11% in 2019. Additionally, that revenue grew from $3 billion in 2019 to up to $250 billion last year. So I'm now going to move on to talking about telehealth visits, meaning video visits that are clinician to patient. So we're talking here about real-time interactions that have both an audio and visual component and are delivered with HIPAA-compliant tools. These can then be structured in a couple of different ways. So we can have system-to-system telehealth, and that is when a group of providers or a provider is contracting with another entity like a hospital to buy their services. So common examples of that are inpatient teleneurology. We also have some tele-ID that is set up this way. Then we have ambulatory services, which is my main area of interest. This can also be subdivided into a clinic-to-clinic service, so that's also called facility-based. And in those services, a patient is presenting to an outside clinic where they might be able to get vital signs, labs, as well as have someone assist with the connection to the remote physician. We can also have direct-to-patient or home-based telemedicine that we've all been doing so much of in this last year. We can provide that to our own patients, and this also had been commonly provided by sort of subscription or consumer-facing services as well. For those of you who've not done clinic-to-clinic telehealth, there are a lot of peripheral exam tools that we can use to enhance that experience. And in theory, a patient could also have this at their own home. These include digital stethoscopes that have very nice sound amplification features. They then connect via cloud-based mechanisms so that you're hearing what is coming from the patient's chest on the other end of the connection. There are also things like otoscopes and magnifying dermatology scopes, so we really can get a decent physical exam in a clinic-to-clinic setting. I'm now going to talk about some of the data for telehealth in diabetes, and this is not a comprehensive review of the literature by any means. Diabetes is actually one of the better studied conditions for telehealth, but I want to hit some of the high points. The first trial I like to mention is IdeaTel. And I mention this really for its historic significance. So this is the Informatics for Diabetes Education and Telemedicine trial. This was an RCT funded by CMS as a demonstration project and was actually part of the Balanced Budget Care Act of 1997. It was led by Columbia University, but it was multi-center and initiated in the year 2000. This randomized over 1,600 Medicare recipients with diabetes who lived in either urban or rural medically underserved areas. It was not targeted to uncontrolled diabetes, and the actual intervention was a combination of remote patient monitoring and nursing video visits. At that time, in the late 1990s, early 2000s, most patients were not necessarily computer users yet. And so part of this intervention involved setting patients up with all the equipment that they would need. So they actually moved processors, monitors, all of the computer equipment into the patient's home. They also had blood pressure cuffs and blood glucose meters that would connect to this equipment and enable the patients to send their data directly to the study. They had a specially designed launch pad, is what they called their mouse pad. So with one button, the patient could connect to video, send their data, access some educational websites, and had the all-important restart button. But as you can imagine, this led to great expense. So each setup was over $3,000, and then there was also the technical cost of deploying these. But it wasn't just the patients that were not so into technology at that time. So particularly for the younger members of the audience, the late 1990s were not nearly as advanced as we are now. So this was the most popular cell phone of the day. And one of the big Christmas movies that year was starring the ever popular Tom Hanks. And the whole concept behind this film is that these two people were professional competitors in real life, met and fell in love on email. And at the time, that was still novel enough to be the focus of a romantic comedy. So IdeaTel did have positive outcomes, arguable clinical significance on these small changes, but they were statistically significant. So in that baseline group, the intervention group had a baseline A1C of 7.35%, as they had not selected for uncontrolled diabetes. They saw a net adjusted reduction of 0.18%. They did see a larger difference for the subset of patients who started with an A1C above 7. But again, the intervention was quite costly, so this was certainly not deployed at large scale, but it did lay the groundwork for CMS covering many modalities of telehealth down the road. Shifting more to the modern era of telemedicine, I'd like to talk now about the TREAT study. So this was a study at the University of Pittsburgh performed by some of my colleagues there. This stood for Telemedicine for Reach, Education, Access, and Treatment. This was a video conferencing-based consultation with the endocrinologist compared to usual care with primary care for patients with uncontrolled diabetes. The patients were at a rural hospital site, and a unique factor in this model is that they had a nurse diabetes educator present with them. So that individual could both serve as a telepresenter, facilitating the connection, and also provide diabetes education, both on general topics and for the specific interventions recommended by the endocrinologist. And the endocrinologist was based in Pittsburgh. And this model that they studied is actually still what they do at the University of Pittsburgh, so it is a kind of unique flavor. Pittsburgh is in southwest PA in Allegheny County, and the intervention site was about 2 hours north, very rural. I've been there. It's largely farmland. And this county of Venango County has one of the highest rates of hospitalization for diabetes in the state, as well as one of the lower rates of education for adults. So again, the endocrinologist was at Pittsburgh. The patients were together with the nurse at the remote site, and they had video visits at 0, 3, and 6 months. Added to that were assessment questionnaires and hemoglobin A1C measurement. The telemedicine group had uncontrolled diabetes with a baseline A1C mean of 8.6, and 77% of them were already using some form of insulin. 25 patients in that group completed both follow-up assessments. The usual care group was selected from the same community and the same group of PCPs. They did not have statistically different baseline demographics or diabetes characteristics, and all of their data came from EMR data collection. They all had additional documented diabetes self-management education as well. So you can see here, particularly by the 6-month follow-up, that they did achieve a very nice separation with better control in the group that received endocrine consultation, though there was some improvement in the usual care group as well. So when you're adding an endocrine service to uncontrolled diabetes, telehealth does improve A1C in these patients, as our endocrinology colleagues would hope to see. It's also important, though, to look at the same type of provider giving this care in 2 different ways. So the Denver VA examined all of their new diabetes consultations over a year's time and compared their telemedicine versus face-to-face outcome. This was also not randomized, so the consult type was based on patient preference, often driven by things like distance. Their visits do include a telepresenter at the primary care site, but that is not necessarily someone trained in diabetes. It could be any kind of technician. And most of their consults in both groups were performed by their advanced practice providers. The Denver VA has a really wide spread, so you can see many locations in multiple states, with the farthest being almost 1,000 miles away. And I should mention that the VA in general has been a major leader in telehealth for many years. They were really ahead of the private sector. So they saw equivalent hemoglobin A1C reductions for the face-to-face versus telehealth groups from baseline to follow-up. And an important point here is that if we're comparing apples to apples, I think non-inferiority is really the standard we're trying to meet. So if you're having an endocrine consultation, delivering that by telehealth should not necessarily be better than in person, but it should be as good. The last study I'll talk about is a home telehealth study, and it's also focused on type 1 diabetes. So this is COYOTE, or the Colorado Young Adults with Type 1 Diabetes trial. This group uses a team care approach that includes both individual clinician appointments and then peer group appointments with a diabetes educator for their age group of 18 to 25. And those patients are making the transition from pediatric to adult care. And this is a highly vulnerable time. So we tend to lose many patients to follow up and often have regression of their control at this time. So in this case, they delivered the intervention via telehealth. That was 3 individual visits, plus 3 of these group meetings delivered via telehealth, and 1 visit in person over the course of a year. This was prospective but non-randomized. The patients opted for telehealth versus standard care, and those doing telehealth uploaded their diabetes devices and got labs in advance of the appointment with reminders to do so. They were really looking more at adherence measures in this study. So in the top set of bars here, you're seeing baseline, and we're going down 3, 6, and 9 months. On the left of your screen is the intervention group, and on the right is the control group. The intervention group really did better at clinic attendance, also at hemoglobin A1C testing, and their device downloads than the control group. And this could be due to some selection bias, that those more motivated patients opted for telehealth. But to get those hemoglobin A1Cs, they were actually making a separate lab trip as opposed to the other group that was getting it all at once. I think this difference is pretty striking. Additionally, the intervention group had 74% of their patients who met the ADA standard of care for this age group, which is to have visits quarterly, and none of the patients in the control group met that standard. There are several meta-analyses of telehealth, and a couple have been published just in the last year or so. These are often looking at multiple modalities at once. So you could debate whether it's better to be a lumper or a splitter here. I tend to be a splitter because it's hard to tell really what intervention is driving the results when they're really very disparate types of intervention. But for an example, in 2019, a study looked at 42 different studies. 8 of these were teleconsultation, so more like what we're talking about. And 34 were various types of device-based telemonitoring. In 25 of the studies, the telehealth groups showed superior outcomes. 2 of them favored non-telehealth care, and then the remainder were non-inferior or showed no difference. We really have very little data on cost analyses with modern technology at this time. I'm going to shift and talk a bit about what we've been doing at Vanderbilt over the past year and what we're planning for the future in our endocrine clinic. We are located in Nashville, and we see over 2 million patient visits annually at our main campus and our connected practices. We've also had a recent acquisition of 3 additional rural hospitals, and that's fairly new for us. Like many hospitals, we first started our telehealth with system-to-system teleneurology, so that's very established. We serve many hospitals both in Tennessee and out of Tennessee. But ambulatory telehealth is newer for us. We really began our programs in 2017. We were quite focused on clinic-to-clinic telehealth prior to 2020, simply because of the reimbursement landscape being different around clinic-to-clinic versus direct-to-patient. So we have a number of sites in our state that are equipped with telehealth equipment. A few of these are pediatric, a few of them are adult, and we have a minority of sites that are considered rural by Medicare services, meaning that they would see Medicare patients there, and the remainder are not. In terms of endocrinology, we were ahead of the curve overall in our institution pre-pandemic. So we had 6 active clinicians doing telehealth. In aggregate, we saw 3 clinic sessions per month to Clarksville, which is about an hour and a half north of Nashville. We had also begun serving the Metro Nashville public school system with 2 sessions per month. They have a very nice model where they have a medical home for their employees who can receive primary care at 5 different sites scattered throughout the school district, and the patients receive that care at no copay. And so we were extending specialty care with them via telehealth. We also had a very low volume direct-to-patient service. So our own health plan reimbursed for that, but no one else in our market did. It was just myself and one other physician. That amounted to just a couple of patients per week at most. One thing we'll touch on towards the end of the talk is that payers and policymakers often express concern that telehealth will lead to increased utilization of services. And this conversation continues to be ongoing. So they believe that telehealth will be added on top of other kinds of care and that will lead to a lot of billable visits. So thinking about this question, we decided to look at some of our pre-pandemic endocrinology telehealth visits and just begin exploring utilization questions in a pilot sense. We focused on the pre-pandemic time because I think during the pandemic, we've all altered our behavior in numerous ways. I have not sent some patients for labs, for example, unless I felt it was really going to make a major difference in my decision-making. And I feel that the pre-pandemic time reflects better what our long-term landscape will look like. So we matched those patients who had been seen by telehealth 1 to 3 with conventional patients. And we matched on primary diagnosis and on clinician. I didn't want to have practice variation of styles between folks causing confounding here. In that time period, most of our telehealth visits were clinic to clinic. So we looked at 75 patients, many of whom had multiple visits. and 225 comparators. Our most common diagnoses were diabetes and thyroid conditions, but we also saw pituitary and adrenal concerns, PCOS, hypogonadism, and transgender care in this group. In both groups, we had more female patients, reflecting who tends to come to endocrinology. The telehealth patients were slightly younger, though that was not a surprise to us. The majority of these visits were at our Clarksville location, and Medicare was not eligible to be seen there. So I have a few patients with VA insurance or other insurance who came to that site, but in general, the population there would be capped at an age of 65. We did not see any racial differences, and that actually differs a bit from what we're seeing in the direct-to-patient literature around the pandemic, which I think is an interesting finding. And then we looked at our median encounters per month of time in the study. Did not reach statistical significance on a difference there. And we looked at TSH testing frequency and A1C testing frequency for appropriate patients, again without significant difference. So I would say our division was still kind of on the early adoption side of the Rogers adoption curve of how innovations diffuse. We had a minority of our clinicians participating in telehealth, though we were working to promote our program. And then, as everywhere has experienced, the pandemic came to our region and really within a couple of weeks drastically changed what we were doing. So at VUMC, we quickly pivoted and took the approach that we basically needed to turn on telehealth for every clinician. So we reconfigured our medical record to allow that. We use Epic as our EHR, and we use Zoom integrated within Epic as our technology. In Tennessee, we had stay-at-home orders at the end of March, and those led into May. So we're here looking at all of the Vanderbilt visits over the past several months. So you can see that we peaked in April with over 2,500 visits some days. They're kind of leveling off in the summer to fall, but then we started to increase again around Thanksgiving with a surge in COVID cases. Primary care and endocrinology have both been big drivers of this. So these are on slightly different scales, but on the primary care side, we had our peak there in April as well with over 7,000 visits that month and had sort of leveled out around 1,000 per month in the late fall. In endocrinology, we peaked a bit later in May. We had almost 2,500 visits that month. And then we have made a strategic decision to try to retain telehealth long-term in our practice. And so we were still seeing close to 1,500 per month in October. This is just another view of our diabetes endocrinology visit mix. So the thin blue line is showing proportion of our total visits that were telehealth. So for a period of time, we essentially went to 100% telehealth services. And then we've leveled off, hopefully in the 50% range for these next few months. One of the really inspiring stories of our pandemic experience here was volunteerism from our medical students. So when the medical students were taken off clinical rotations in early March, they self-organized into teams to help with all kinds of things. And one of them was telehealth. So some students that I work with on telehealth projects at our student-led free clinic pulled together a large group of students. They made a curriculum for themselves. They did peer training on how to set patients up for telehealth and troubleshoot our telehealth visits. And then they began calling patients ahead of the visits to help them prepare. In the before times, we would have given patients a handout in the clinic and had a nice, calm discussion about what to expect with telehealth. But with moving so many of our patients so rapidly, we really needed a better way to reach them. And they ended up calling over 5,000 patients, and we're working on some publications around this as well. It was also quite reassuring to many of our clinicians who felt like they had an assistant to help them get ready for these visits. And we did see improvement in achieving a successful telehealth visit with this pre-call. In the endocrine practice, we've made several changes that are really thinking about long-term view of telehealth. So we've gone ahead and changed our schedules to have designated telehealth time. And I suspect that that'll probably level off somewhere in the 25% range eventually. We're still at 50% for now. Our diabetes education team early on began messaging all of our diabetes patients about uploading their information to cloud platforms. So we made a decision to focus our efforts on Tidepool. This is a product provided by a non-profit organization that allows many different kinds of diabetes devices to be uploaded and then displays them in a uniform way. And I'll show you an example of that. But we do still use many of the alternate device-specific platforms depending on our patient's level of comfort. Gluco is another product that receives data from multiple kinds of devices, but it does have a small charge for most patients, and so we don't favor that. And none of these integrate with our EHR, so we look at all of these cloud platforms to get this data. However, this has started to benefit our in-person clinic as well, so we've encouraged our patients to continue using these. So when a diabetes patient comes in, if they've used this service, we can just grab that data and we don't have to physically download their device as part of our intake process. For the non-endocrinologists in the audience, this is what we see when we get this data from cloud services, and here I'm showing a Tidepool example. This is not the patient I discussed at the beginning of the talk, but she's also very well controlled. So I could toggle through different views, 1 week, 2 week, 4 weeks, and what we're looking here on the large panel is the median trend line of this patient's blood sugar. I could also page through individual days and look at specific events. In the upper right there, we're seeing this patient's time spent in hyperglycemia, hypoglycemia, and then in target range. Time in range, incidentally, is becoming an important diabetes metric, and over 70% is a goal, so this patient is doing very well. I can see her average glucose, standard deviation, an estimate of what her A1C might be. And then this patient also uses an insulin pump, so her settings and bolus events are available from other screens. We've also established a team in our clinic to work on improving our intake and our post-visit processes to be sustainable. We've elected to do intake calls to our patients 1 to 3 days before their appointment instead of trying to call right before the clinician appointment. So this is the call where we do things like review the medication list so that reconciliation can then be finished by the clinician seeing the patient. We found that this allows us to stay on schedule, which is a big patient satisfier, and it also just simply fits better for our staffing ratio. We also established a telehealth room in our clinic for those patients who come in but have an off-site provider. So sometimes this happens because we have a few clinicians who, for their own medical reasons, are working from home, or sometimes the patient has multiple visits on campus that day and just doesn't want to move their endocrine appointment. Post-visit, we try to get labs within our own system just so that they display in our EHR. VUMC has a number of outlying clinics, and we also have a relationship with some Walgreens walk-in clinics. But many of our orders end up being faxed, and we don't have EMR integration for most outside lab services. Here Everywhere allows Epic organizations to exchange information, but does not catch that many of those patients. And I do see this lab ordering and lab receiving issue is one of the things that I think will be a barrier to enthusiasm around sustainability for telehealth. We've also been providing our diabetes education and medical nutrition therapy services by telehealth, and those have been reimbursed throughout the public health emergency. It remains to be seen how that will be structured once the public health emergency is over, which has at this point been extended to April. In the future state, I think we need to work on finding a balance to match what the demand is for in-person versus telehealth visits, just from an operational standpoint and keeping our clinics full. I also think we need to make decisions with individual patients about how often telehealth is appropriate for them. So this can include expectation setting around patient responsibility for labs and data sharing. All of our patients with diabetes need to have good vital signs and an exam at least once per year. That certainly could be done in a primary care office if care is well coordinated, But for those of our patients, particularly young patients with type 1 who kind of see us as their surrogate PCP, we need to make sure that's getting done. And I would consider home hemoglobin A1C testing for some patients who wish to do it. We'll cover a little of that data in a moment. And then finally, I think there could be much better integration of other technology and tools and perhaps some role for remote patient monitoring services. During the pandemic, a group in Slovenia actually looked at the acceptability of home A1C testing in their patients. They offered home fingerstick A1C kits and a telehealth visit, and 98 of 100 patients opted to try that. And they did see high satisfaction with this. In this study, 90% of these were actually telephone calls, and then a smaller amount were video calls. I have not used a lot of home hemoglobin A1C testing over the years, and sometimes a patient will bring me that data. I admit I've been a bit skeptical, so I decided it was time to dig in and really understand how high quality this is. You can see prices of these at a couple of major retailers, typically not insurance covered, but maybe something like FSA reimbursable. So for two different kits, I looked at correlation with standard lab assay. So for one, we had an R-squared of almost 95% and also high within subject correlation, the coefficient of variation at 2.7%. The other kit performed slightly lower, but both of these are within the range that we see between the point of care machines in our clinics and lab gold standards as well. I've mentioned remote patient monitoring a number of times, so I wanted to take a minute to define that. This is using digital technology to collect medical and other forms of data from patients in one location, transmit it elsewhere for assessment and recommendations. And this can also be used to support care of other complex chronic diseases. I think it works best when we're applying a population health approach, so refiguring how the clinic looks at managing a group of patients or how another entity looks at managing a group of patients is, I think, a better fit than just adding it to a standard clinic setup. And some authors have proposed the concept of a digital diabetes clinic. So ideally, this would include data from all patient devices to be collected in a standardized output into the medical records that we already use. And there's also potential to better integrate some of the diabetes self-coaching apps that are out there. So overall, we have a lot of technology available for diabetes patients, but we may not be using it to the fullest due to lack of integration at this time. You could see that something like this could really facilitate a lot of telehealth and less physical overhead for clinics if we were maximizing all of this technology. Some other enhancements we've done at Vanderbilt over the course of the pandemic are refining our technology policies to be better prepared for what we think future restrictions will be. So we started with multiple backup technologies, and we've refined that list to just a few that we think will continue to meet HIPAA requirements long term. We've also adjusted our check-in process when the patient comes to their virtual visit to include some key compliance and financial elements. And we are actually piloting a high-touch patient tech support model for patients at risk that will be modeled on what our medical students did. We've also iterated on our patient instructions several times, and we now offer full instructions in both Spanish and Arabic, as well as English. As I mentioned, we use Epic with Zoom integrated. And one of the big problems I foresee in the future is that when we have a shift in reimbursement, which we will touch on shortly, it's going to be hard to tell who's able to have telehealth and who is not. So we have designed an indicator within our EHR that basically acts as a back-end insurance translator. Patient's insurance information is in the system. This then translates that into a display that tells us in plain English what the patient is eligible for. So right now, almost all of our patients are still eligible for direct-to-patient and clinic-to-clinic telehealth. In the future, some will likely be eligible only for clinic-to-clinic and some for no telehealth. We also display this in a different way on our whiteboard where we're looking at our patient schedule for people who like to look at it there. Our little camera icon is how we connect to our telehealth visits. We also have columns to tell us if the patient has activated their patient portal, which is a prerequisite to joining the visit, and where they are in their check-in process, whether it's not started, in progress, or complete. Coming back to telehealth as an industry, I think we're going to see a lot more entry into the chronic care space from direct-to-consumer companies. So historically, direct-to-consumer care really focused on acute care. We're already seeing several examples of boutique care, looking at more chronic conditions or health maintenance. So Nurex, for example, is a contraception service. There are many different men's health services now out there. And Afrezza, interestingly, is the inhaled insulin product made by Mankind. They have a feature on their website where you can click to request a physician visit, presumably for the purposes of getting a prescription for Afrezza. So I see all of this as a reason for us to continue providing chronic care for safe conditions via telehealth. And our patients really prefer that. They want to see their own clinician. This survey data is from 2017, so before we had such broad use of telehealth. But at that time, among 4,000 respondents, about half wanted to see their own clinicians on telehealth. A third or so would be willing to see a different clinician in the same group, and a much lower number would be willing to either see another group in parallel or leave their current group to see one who offered telehealth. As we move towards the end here, I'd like to talk briefly about the regulatory and reimbursement landscape and some of the changes that have happened this year and what we expect to be permanent or not. I think it's important to note that we regulate telehealth at several different levels. So one is at the federal level, largely through policies from Center for Medicare Services, although some of those are statutorily defined. So this tells us who can participate in telehealth and what Medicare services will be covered. So that includes type and where the patient can be located. States define their own licensure and prescription requirements. They also determine their own Medicaid coverage and commercial payer requirements, although commercial payers can choose to be more permissive with their services and sites. And in non-parity states, they can set different rates for telehealth versus in-person visits. Parity means that they have to provide the same reimbursement for the same service regardless of delivery. A lot changed in 2020, and some of it will be permanent, but unfortunately, some will require additional action to be made permanent. So in the federal side, pre-COVID, for most services, patients needed to be in a rural location, and this is defined by Medicare, by the way, and they could not be in their own home. We were starting to see some moves towards more progressivism here. So in 2019, both stroke and home hemodialysis had exceptions made for this. Next generation ACOs and Medicare Advantage plans were also permitted to be more liberal starting in early 2020, though not required. Most of the Medicare level changes have been part of the public health emergency, which now extends until at least April 21st of this year. But many of these will expire and revert back to the state I just discussed when that is over. So during this time, home has been a qualified site. The Office of Civil Rights actually enacted a waiver of HIPAA enforcement, allowing more flexible technology use. And they've also been paying different fees to kind of help support patients getting access. At the state level in Tennessee, we were doing reasonably well. We had a parity requirement covering clinic-to-clinic telehealth with no geographic restriction. And in Kentucky, I'm sure there are more experts in the audience on this, but my understanding is that you did also have parity for Medicaid and commercial services and already had a permission to do home telehealth. We've had emergency licensure from several of our border states during this time, which was much appreciated. And in August 2020, Tennessee passed a law making home a qualified site, which is a big change, and continuing to require parity for our Medicaid and commercial products through 2022. So this means that all commercial insurers operating in the state would need to cover telehealth. On the private payer side, we also saw a significant expansion of some of our major market payers, including National Aetna and National Cigna, opting to cover telehealth at home for the long haul, even independent of this law. So back to my patient. I saw her in the office in March 2020, and then she had her first telehealth appointment in June. We managed to connect beautifully to the preferred service, which we really appreciated, and she had a local A1C drawn. We did have some challenges with the video quality, and I actually noticed this in several of my Hopkinsville patients. We didn't have quite enough bandwidth for a really high quality connection. So we were able to accomplish what we needed, but if I had needed to, for example, examine a skin lesion, I would not have felt comfortable. I then saw her 2 more times on telehealth in 2020, and by December, she had done something and ended up with better video quality, which is terrific. So there will be a number of regulatory issues that impact how I'll see her in the future. I do actually have a permanent Kentucky license, but most of my colleagues do not. We will need to see what happens with CMS regulations after the public health emergency. But at this time, we anticipate they will revert to the prior state until there is some legal action taken on that. And then finally, broadband does not prevent me from seeing her, but is a major issue for a lot of our rural patients. Changes at CMS to the geographic requirement and the home requirement will require new laws to be passed by Congress, but I'm really quite optimistic about this. So last summer, about 20 different bills were introduced with bipartisan engagement, and I think we will see this come back around. I do think we're going to see change at Medicare, just might not be as fast as we want. In this environment, I think we've all seen telehealth as one of the silver linings of the pandemic, and it's become much easier to advocate with policymakers because telehealth is now a part of many people's experience. There is still, I think, concern about the overutilization question, and that's an area where I think we need to continue to make arguments as well as establishing quality for other conditions. Other considerations as we continue to normalize telehealth needs to be attention to equity issues. So some data from Penn just published this year indicates that they were not seeing equal access to telehealth in different racial and ethnic groups. And we have some data suggesting that's the case as well, that direct home telehealth was not reaching everyone equally. We also need to think about balancing just the business of this. And in a fee-for-service environment, we have a much improved landscape, but alternative payment models can still be a bit more conducive to telehealth. And finally, there's room for research here to look at quality and other conditions, utilization, optimization of how we do this. So if anyone is interested, please dig in. I want to thank our Vanderbilt telehealth team. That lower right is us on a hike a couple of years ago. We had wonderful engagement throughout this from our legal teams, from health IT, from many department telehealth champions, the medical student volunteers again, and the patients that we serve who stepped into this with us. I thank you for your attention, and I believe we have some time for questions.
Yeah, sure. Excellent presentation, Dr. Griffith. And if anyone has any questions, you can unmute your microphone and ask. Also, what we've been doing, if you would want to type your question in the chat area, I can ask her. I can pass it on to Dr. Griffith. So, would anyone have any questions to start here?
Thank you, Dr. Griffith. Are you all, one of the things is that the problems of improving adherence to self-care recommendations, these are things that we think would improve with using telehealth. Are there any efforts to try to reimburse for those, or how do we promote that aspect of diabetes care?
So in terms of adherence to health maintenance?
Yeah.
Yeah, so I do think, that data from Colorado suggests that patients were staying more engaged with telehealth, at least in a particularly high-risk group than compared to usual care. We have not gathered complete data yet, but incidentally, my education team here is reporting significantly better adherence to our diabetes self-management appointments on telehealth versus at home versus coming into the clinic. I do think that keeping good track of the fact that we're still hitting those quality metrics is important. So, pandemic time, I think, has altered, some of the box checking that we need to do, like getting a urine microalbumin, for example, in every patient annually. But I think that continuing to track that and report it at an organizational level is going to be really important in the reimbursement arguments and in the policy arguments around telehealth.
Hi, this is Satya Krishnasamy. Good morning, Michelle. That was a very nice presentation. So the question I had was, we are transitioning to Epic from Allscripts, and I know you guys use Epic. So one of the things we are trying to do was getting to do the, upload them in MyChart, get the data available ahead of time, the prepping for the clinic. So how were you able to accomplish that, getting in the CGM data or pump data or the glucose data?
Yeah, so that's a good question. We had, at the very beginning of this, we asked patients to use the MyChart feature, which basically they can go in and type out their blood sugars or blood pressures. We did not see much uptake with that at all. We have seen a lot better engagement with our patients using the other cloud services, and then we just retrieve that from the cloud service. So I'll save a screenshot, for example, into the chart, or if there's something very complex, we can download a whole PDF of that and then upload that into the media section of Epic. Honestly, I feel like the data from the device is more accurate and certainly gives us more information with pumps and CGMs. And I'm not sure why, but patients are just much more willing to do that than to even type out a few days of blood sugars in the EHR. So I think for endocrine practices, I would certainly encourage that. In the primary care space, that is probably not practical at all. And so MyChart, the self-entry of those can be a really nice feature. As I noted, none of these cloud services really integrate with our EHR. And I think, you would probably, as an endocrinologist, not want full integration because I don't see any way that you would retain all the data that's available there. But if, for example, the ambulatory glucose profiles could feed into Epic, that would be terrific. And that is possible. Epic is able to link with many, many other services, but it's usually a lot of coding at the individual institution level. And so we have not tackled that yet.
Okay, thank you.
Michelle, Steve Winters here. I was curious to what extent you used the physical exam, the virtual exam.
Yeah, so honestly, in my practice, I have usually done minimal exam on my telehealth visits. I feel like it does not make a huge difference in what I'm doing. However, if I'm concerned about edema or something like that, I will ask the patient to hold their phone down by their tibia and press on it. I will have patients walk sometimes at home. And I do think you get a lot of observational exam too, especially if you know a patient, you can really pick up on quite a bit. So I have not, even in my clinic-to-clinic practice, made a huge point of using the remote stethoscopes, but those have been very helpful for some of my colleagues in infectious disease, cardiology, things like that.
Yeah.
One other thing I'll say, go ahead.
Now, there was a question here from Dr. Priya Krishnan about, have you used any smart programs to triage the telehealth reports?
I'm not sure I'm familiar with what you mean.
Okay, because this is Priya Krishnan. Sorry,
Sure.
because you'll get a lot of data with the automatic uploads. Is there any way that you have identified like trends that a program or something that can identify trends ahead of time and kind of triage these patients into, hey, this person needs to be seen right away. This person, I think that is probably what we would be looking at in the future. So I was just wondering if you had any kind of system that did that or any program that did that?
Great question. We do not, but I agree with you that basically layering some AI on top of the data feeds is a great idea. One of the things that I'm also involved in with our population health group right now is we're doing a small remote patient monitoring pilot, and we're essentially just using the Freestyle Libre and its dashboard to monitor a population of patients. And we don't really have alerting AI on there, but we have filtering mechanisms. So we can basically mark the patients that have hypo or sustained hyperglycemia and then use that as a way to decide which patients to reach out. That's kind of us dipping our toes into that space. And if we see good success with that, then we may try to invest in a more complex system.
Thank you.
Would anyone have any more questions? If not, Dr. Moksha-Gundam, would you like to let her know we got a little something for Dr. Griffith?
Yeah, it's a tradition for anyone who comes to Louisville and speaks. Of course, if you're basically here virtually. So as you know, we have the Slugger Museum. We make the baseball bats for all Major League Baseball. So Jason, you can show her the bat that you will receive.
Yeah, you're gonna get.
Yeah,
you're gonna get one of these here in a few days.
Thank you. That's
we'll send it
beautiful.
over to you. Okay. And thank you very much for a very nice talk. And we'll keep in touch, and maybe we can collaborate on some of these things.
That would be terrific. And good luck with your epic transition. It will be worth it, but it's always growing pains. So good luck.
Thank you.
Thank you.
Thank you all. Have a great day.
Thank you, Dr.
Thank you,
Griffith.
Michelle.
And everyone, we'll be back here again next Thursday morning, 8 a.m. We'll actually be talking about GI things with Dr. Ben Rogers from the UofL GI department division. And again, that'll be once again 8 o'clock next Thursday. And appreciate everybody joining us this morning. Again, appreciate Dr. Griffith, and her talk this morning is definitely very timely. So thank you, everybody, and we'll see you next week.
Thank you, Jason.